Anybody have any questions before we begin discussing these case studies? And so the good news is you guys are, let's see, this is fall. You guys will graduate fall, spring, summer, fall. You guys will graduate 22 December. Yay for you guys, because spring 23 will be the next gen NCLEX. Maybe.
That means take your test before April of 2023.
Absolutely. Test ASAP. Never let any grass grow under your feet when you leave nursing school. Always test ASAP. And if you want to practice in another state, that's great. Test if it's not a state with, it's not a compact state. There's a couple of states that you may want to go test in, or you may want to live in. It's best to test in Texas, and I'll tell you why. When you get your blue card, you do so through the Texas Board of Nursing. You will take your jurisprudence exam through the Texas Board of Nursing, and they have all of your documents. And so if you decide that you don't want to test in Texas, then it becomes, unfortunately, your responsibility to contact the State Board of Nursing where you want to test. And in my experience, I've had a couple of students that had other life plans, like getting married and having babies, which they're all great things. I did both of them. But sometimes things stand in the way, and sometimes it's not always easy to get your documents to the state, because you have to, it's the difference between licensed by examination and licensed by another form, where you have to provide evidence of your degree to see if your degree plan follows that state of nursing Nurse Practice Act. So it's better, the University Concordia will be able to give you your AOG, which is your graduation, that your graduation requirements have been met. And as soon as they send that to the board, then you can test as soon as they receive that, and it takes a less amount of time to do that. So that's something to think about going forward. I mean, you have till next year, and if you are very sincere about your efforts to test in California, Ohio, New York, there's a lot of other states, and I just know those offhand because those are the students that I've been involved in helping. The university actually can't help you do that. It's not something that they're even able to do, even if they want to. So if you're thinking that that's the direction you're going to go, you have to begin planning, certainly at the beginning of your next semester, although I don't recommend it, simply because it's just something you want to, the whole idea of nursing school is to get a license and to practice. So because every Nurse Practice Act, this is something to remember going forward. Every Nurse Practice Act, they define the nursing practice for that state. And not only do they define it, they regulate it. So because they define it for that state, it may be different than the definitions that you prescribe to through the state of Texas. So it's much easier to transfer your license by examination, than license by exchange. It's another E word, but it fails me at this time. Do you have anything to add to that, Dr. Starkovich?
No, I don't think so.
Alrighty. Well, that's just a couple of general comments to begin this lovely exchange of information. And another thing, there's a couple of things that we haven't talked about before. HIPAA. HIPAA is a big, huge deal. I think you've probably signed some documents stating that you will respect. It's from the Health Information Portability Act, which means that your health information follows you. However, you as a nurse are only on a need-to-know basis, and it's only for your patient. And you can't actually transfer any sort of document that could end up in the wrong hands as far as someone else doesn't need to know. So HIPAA is it's like sensitive. Say you go to clinical and you have a patient that's on your block, and you just on the block that you live in on, and you think it's okay to just to pick up their chart and look at it, and or post something on the internet that says, hey, I'm so glad to see my neighbor got over her whatever C-section and had triplets. Well, that's pretty specific information, and so you have to be very careful. Certainly social media can be your enemy, and I've had some exchanges with students because of that. So be very careful. And then also with regard to civility, there's some times in nursing where you may witness incivility. Incivility is one of those things that you certainly report. The best person to report it to certainly would be your supervisor. If you don't report it, you become certainly a part of the problem instead of a step toward the solution. So those are some things that you will see coming up in your practice along the way, and certainly you'll go through those things in leadership as well. So those are just a couple of opening comments as we began this lecture. So Dr. Starkovich, will you post the chapter 16 case study so we can just chat it up a little bit about that?
You mean like in the chat or share?
Well, it doesn't matter. I mean, I thought I was going to post, I was just going to bring it up like chapter 16, but we don't necessarily have to do that. Chapter 16 speaks to anti-inflammatories, arthritis, and related agents. And so as far as anti-inflammatories, what's the #1 medication that you will give as far as anti-inflammatories? What's NSAIDs? Absolutely, Michelle. Very, very good. Very good. What are the most common adverse reactions of NSAIDs? Ulcers, there you go. Stomach ulcers, absolutely. GI upset, absolutely. Diarrhea, constipation, gas, etc. So certainly bleeding. And so what are you going to look for in your patient? What signs, what symptoms would you check for as far as bleeding? What would you look for? Black stools, absolutely. Bleeding gums, vomiting up blood. It can also, coffee ground emesis, absolutely. They also inhibit platelets, which is the reason why the bleeding happens. Platelet inhibition, bone marrow depression, certainly chronic use. A lot of times you can actually have anaphylaxis. That's rare, of course. Mouth sores may occur, rashes, etc. Those are not as common as the other stuff, dyspepsia, GI, constipation, etc. Key considerations when using anti-inflammatories. Certainly your older patients may be more susceptible to the CNS effects, and certainly the GI effects as well. Sometimes dosage adjustments are necessary. The geriatric population are actually more sensitive to naproxen, ketorolac, because of the increased toxicity. Certainly their liver function is not as good. A lot of these drugs are metabolized in the liver. Certainly the kidneys play an active role in excretion. Drug metabolism is mostly predominantly in the liver as well. NSAIDs sometimes should be avoided if at all possible, particularly older adults when they have increased liver complications, for sure. Gold salts is something that you won't see often. However, it's used for arthritis. That carries its own set of consequences and side effects as well. As far as teaching, patient teaching, what are some patient teaching opportunities for GI? For anti-inflammatories or anti-arthritic agents. Take with food, absolutely. Absolutely. Biggest thing to do is take with food. Always make sure your patient is well hydrated. If their kidneys are on the struggle bus at all, you certainly want to make sure that they're well hydrated, and you don't want to put their kidneys on the struggle bus. So you always want to make sure that they have a proper fluid intake, for sure. Obviously, teaching. Avoid any sort of emergency procedures that might induce vomiting. Of course, hopefully, if somebody takes a toxic overdose and they need activated charcoal, that's not something that they can help. Sure. Supportive care measures. What are supportive care measures? What would supportive care measures look like for any of your patients on any sort of medication at all? Supportive measures. What does that look like? Rest. Helping manage side effects. Absolutely, Michelle. Rest also. Make sure your patient is hydrated, and certainly keep their body temperature down. If somebody's on anti-inflammatories and or rheumatoid medications, intake and output, absolutely. And they're outside working in the heat, that's going to raise the toxic levels of these drugs in their system. So make sure, they not only hydrate well, but they do supportive measures would include making sure that they maintain optimal body temperature as well. So that's pretty much all of you. Will cover anti-inflammatories a little more in depth next, rheumatoid medications next semester. So, and those will be things like methotrexate, steroids, and all those things that treat the arthritic conditions in general. So, does anybody have any questions about the Chapter 16 anti-inflammatories? If you've had a chance to look over your study guide, there's some questions that relate to that study guide. Does anybody have any questions about that? Not yet. There you go. All righty. So we're just tying up some loose ends today. We'll go over muscle relaxants. Pathophysiology of muscle relaxants. Muscle spasms are often a result of injury to the musculoskeletal system, overstretching a muscle, wrenching a joint, tearing a tendon, and certainly these can cause violent pain. The spasms are actually related pathophysiologically to a flood of sensory impulses, basically stemming from the spinal cord to the affected area. If you're familiar with the gate control pain method, if you burn your finger, the signal goes from your right, say if it's your right index finger, it goes up to your brain and then goes back down and tells your finger that it's going to hurt. So a gate control theory of pain would mean if you hit or burned your right finger, you rub your left arm, and it kind of mutes the signals that are going up the right side of your upper extremity to your brain, and it kind of reroutes them. So it's kind of it kind of tricks your neurosensory system. Certainly, muscle spasticity can also be the result of stretched neurons. And so sometimes if you've stretched something, the muscles as well, they become very spastic in that they can begin to spasm. And that's, if you've ever had a backache, and I have, it's actually very painful. It's very painful, and muscle relaxants certainly come in handy when they're needed. Unfortunately, the muscle relaxants do have a lot of side effects. Hang on, I'm reading this. Hang on, so discuss the difference. Okay, so if it's a central muscle relaxant, let's see, that's actually just a spasmodic or spasmolytic. It alleviates the pain in a just kind of, it acts through the central nervous system. And so direct acting is, let's see, help me out here, Dr. Amy. Let's see, they would actually, actually, I don't know. I don't think there's much difference. Because like baclofen, which we'll talk about in a minute, is a central acting. I guess maybe some of them are more peripheral in nature. Let's see. Oh, you know what? Some pain relievers or some pain relaxants, as far as a direct acting one. Have you heard of Botox being injected for pain, Dr. Starkovich?
No, I haven't. Sweating, yes. Migraines, yes.
Yeah, so maybe that's more direct acting. I mean, I had it for wrinkles. Let me look it up. Central acting versus direct acting. Let's see what that says. I think, let's see. Central acting are used medically to as adjuncts, physical therapy, etc. Direct may inhibit like muscle spasms. Let's see. Central acting are used for centrally acting muscles. There you go. Boy, that is injury, musculoskeletal disorders. Direct acting are muscle skeleton that inhibit the contraction by decreasing calcium release from the muscle cells. So they act directly on the muscle themselves versus using the central nervous system, etc. Does that make sense? Okay. Yeah, migraines, Millie, you're right, migraines. So the central is the central nervous system, and then the direct is more, has a direct effects on the muscles, and has to do with the calcium channels in the muscle cells. That's what I said. Yay. All righty, see, where was I? So baclofen is a central central acting muscle relaxant. So if something goes to the central nervous system, what's one thing you should never do when you're taking anything that affects the central nervous system? Absolutely know what? That too. Alcohol, absolutely. No alcohol. And a lot of those CNS depressants, especially when you're talking about muscle spasms and a host of other things, these drugs not only they numb your central nervous system because they numb the muscle spasms, right? Because they're centrally acting. So for that reason, you must always, always, always taper these medications as well. So you can imagine if you all of a sudden quit taking them, guess what? Your central nervous system responds with a hyperactive sort of rate, and then of course the muscle spasms will respond in kind. So they always must be tapered. And something else they do is because the cholinergic effect, they also can cause constipation. So you always, something that you must be mindful of is dealing with maybe increasing fiber or doing other things that might help your patient not be constipated. Let's see what else. Certainly if your patient has, sometimes I've heard of patients taking NSAIDs with low dose muscle relaxants, but you always have to watch out for the complications between the muscle relaxants, and it's a synergistic effect. Synergistic effect, of course, you have to watch for bleeding, and I mean, certainly you can take them. It's actually called a pain cocktail, and certainly it's it's a ladder control kind of thing. Ladder control in pain is you start out with the least toxic, if I will, drug, if I can use that term, drug, the least drug that will cause the least dependence. And so then you add things. So if you have a muscle relaxant on board, very low dose, and it's still not taking the edge off the pain, well, then you can add an NSAID, knowing that it does, of course, affect the gastric system, and certainly, can add to the dizziness. And somebody mentioned earlier, as far as driving, operating heavy machinery, you always have to watch for that too. But it's done, Sabina. You can do it. It's not so much an interaction, but it has a synergistic effect. So let's see. We talked about I was mentioning hypersensitivity. If you see any reaction or liver dysfunction, certainly that may be the time that your provider may want to discontinue it. Basically, if you have a reaction, a hypersensitive reaction, or any sort of signs of liver dysfunction, yellow jaundice, certainly you don't want your patient to become toxic. It's usually tapered, however, over 1 to 2 weeks to prevent the development of psychosis and or hallucinations. It's used cautiously in patients that have immobility, posture, or balance problems. Certainly you don't want them to be injured. Sometimes you can actually get Baclofen through a pain pump, and certainly that's a whole nother story, and certainly not for this class, but just know that that's an option. That's one of the challenges you'll have in critical care, and certainly orthopedic surgery, and maybe even trauma. Let's see, of course, patient teaching, avoid adverse effects, monitoring, of course, monitoring pain levels. Remember, pain is what the patient says it is, and certainly offering encouragement, as I know you all will do as fabulous nurses. Nursing assessments, of course, hypersensitivity. Sometimes these muscle relaxants can cause cardiac depression, so that's another thing. Usually people, if your patient's in the ICU and or post surgery, they'll be on continuous EKG monitoring anyway. Renal renal or hepatic dysfunction could alter the metabolism and excretion, which is something that you watch. I talked about Botox. If it's given for any direct muscle action, then of course you always watch for local infections as well. Always assess temperature, skin color, CNS orientation, bilateral grips. If you're doing a focused assessment, musculoskeletal assessment, balance, of course, always, because these drugs do cause constipation. And I believe that's about the end of that story. And certainly if they're allergic to that medication. Watch for that as well. Dr. Starkovich, do you have anything to add to that?
No, I think we covered the basis. Definitely no alcohol or heavy machinery until you're used to it. But other than that, I mean, I think you got it.
All righty. Does anybody have any questions? Ding dong.
The witches.
Complaints, comments? All righty, we're running through.
Just a note, Dr. K, since, we had a pause. I've been getting a lot of emails about if you're supposed to know the specific dosage ranges of drugs for children and adults and different diseases. You do not need to know that.
No, you don't.
Yeah, just make sure you know what the drugs are, their major side effects, adverse reactions, and what they're for. What are their indicators? Okie dokie. And
So there's a question about COX inhibitors, COX-2 selective inhibitors. The reason why they're a little beneficial or more beneficial than NSAIDs is they are usually associated with a reduced or reduction in GI complications. And the difference is, it's like the difference between, unlike NSAIDs that block, NSAIDs block COX inhibitors 1 and 2. The newer ones only block COX-2 enzymes. And it has to do with the prostaglandins. So some of the NSAIDs are COX-2, some of them are not. And the advantage of COX-2 is that they have decreased GI toxicity. And if you're really getting down in the weeds, one of them has a little lighter effect on the cardiovascular complications as well. So that's certainly way down in the weeds for sure. The naproxen is one of those that carry kind of a high risk for bleeding, for GI bleeding. And then you have Celebrex, and you have others to be perhaps least caustic to the GI tract. It's just the difference between 1 and 2 and the effects on the GI. All righty. I hope I answered your question, Sabina. So we have narcotics and narcotic antagonists and anti-migraine agents. So what is a narcotic? What sort of drugs are we talking about when we're talking about narcotics? Opioids. Jasper, they're only illegal if you buy them on the street. These are prescription drugs, and I'll tell you, you can buy them on the street. I wouldn't. But They're controlled substances. Some of them are yes, absolutely. Narcotics and narcotic antagonists. So if there's some of the narcotics that you will see in practice, certainly codeine, oxycodone, morphine, and hydromorphone. So morphine is, of course, given for many specific reasons. Morphine is what system does morphine affect the most? What of your systems does morphine affect the most? It's actually the respiratory system. Morphine has the most profound effect on the respiratory system. In fact, a lot of the hospice patients, if they're having respiratory difficulties and or respiratory, what word am I looking for, Dr. Starkovich? Well, it causes respiratory depression. Certainly it causes morphine causes respiratory depression. If someone is on hospice and they are struggling to breathe because they have respiratory distress, there you go. That's the word I was looking for. Then you can, if they're having at the end of life, sometimes they have retractions and they're struggling to get to breathe. You actually want to induce the work of the respiratory system, and so that does cause respiratory depression. So if you have a patient on morphine, you always make sure you do a respiratory assessment and certainly a pain assessment. Morphine works very quickly. It works within 15 to 30 minutes, but it doesn't last very long. So you can give morphine very frequently, particularly post-surgically, trauma, of course, especially if people are on ventilators as well. Analgesics, while analgesics are given for moderate pain, morphine is given for severe pain as well. Morphine, the difference between morphine versus hydromorphone. Hydromorphone is anywhere from 5 to 10 times more potent than morphine. You'll see patients in the ER come in they take their try to commit suicide by taking an overdose of Tylenol number 3. The reason why it's more toxic is not the codeine, it's mostly the Tylenol. Tylenol is very hard on your liver, and unfortunately sometimes you can't give enough, it may be too late to pump someone's stomach, and or you can't give someone enough charcoal to reverse that, to reverse the Tylenol damage, not the codeine damage. So if indeed there's acetylcysteine can actually reverse, yeah, there you go, Sabina, yes, you could give it the acetylcysteine, absolutely. And then there's something that you can also give for morphine, to reverse morphine. If your patient has, say, a respiratory rate of 8, and they've been given a fair amount of morphine, certainly you can give them something called naloxone, because that's actually a narcotic antagonist as well. So let's see what we have to say about this. Elderly patients, of course, would need less. They're more likely to experience adverse effects. For sure, the central nervous system and cardiovascular effects as well. You certainly wouldn't want to give a bradycardia, morphine. Older patients certainly have the renal and hepatic impairment and are more likely to have toxic effects, for sure. Safety measures, of course, for anyone, side rails, making sure you check your patient often. Morphine also has a tendency to decrease or bowel sounds. So you always want to make sure you check for bowel sounds, and you always want to also make sure that your patient is voiding properly, because morphine will also relax the smooth muscle of the bladder, and you may need to check output on your patient as well, particularly post-surgically. Let's see. Maintain open airway, of course. Make sure emergency interventions are handy. Vasopressors certainly can manage narcotic overdose, and certainly naloxone can as well. Let's see. Continuing, yes. Continuous monitoring, of course. What else? There's another drug called naltrexone, and it's given particularly for narcotic and or alcohol withdrawal programs, but that's something that you probably won't navigate in the nursing home or in the LTAC. Let's see, comfort measures, rails, ambulations, bowel programs for treatment of constipation, like baclofen. These cause reduced gastroparesis, encouragement, of course, pain monitoring, safety measures, no driving, avoid making important decisions, which would include, of course, being in nursing school, always having a responsible party available, and somebody that can help, get you help in case your patient needs help. Somebody checking on that patient as much as possible. Let's see. Pregnancy, of course. Contraceptives while taking these particular drugs. And certainly breastfeeding would be something you would want to maybe, let's see, find another method for feeding the baby other than breastfeeding. Alrighty, that was fun. Any questions on that? Hang on, Dr. Amy, I have to go check something. I'll be right back. Give me 1 minute.
Okay. Yeah, I don't know if you saw the chat, but narcotics are a broader class of medication. So opioids are part of the narcotics family, I suppose. But not all illegal medications are narcotics. Like cocaine is a stimulant, but in the hospital we use it as an anesthetic agent. For the skin, if we're doing a biopsy, or even if somebody's getting a rhinoplasty or something like that, they'll usually have some cocaine. Anyway, any other questions?
All right, I'm back. Sorry, I had soup on the stove. Had to go turn it off.
Good. Okay.
Yeah, I know. So I was just telling Dr. Amy earlier, I made chicken potato soup. I bought ready-made chicken from Brandl's. I took potatoes and I cooked them in the microwave. I added butter, squeezed garlic, and get it in a tube, squeezed cilantro, a real whole bell pepper. That's the only, the real thing I put in there, and you just put them in there, voila, potato soup. Lots of seasoning. All right, there was no charge for that recipe. That was a total freebie. So we only have, I hope so. All right, Millie, I'll have to tell you guys during the exam review, and Michelle, if it was good. It's really easy racine to make. I'm in my family known as the microwave queen. Well, you have to be queen of something. I can actually make roux in a microwave for gumbo.
What?
So, Yes.
I don't
My,
know how, because I sure did try to make like stroganoff in the microwave when I was in college. It did not, meat in the microwave did not turn out well.
yeah. Well, you have to put the flour in the microwave, and you have to watch it, and then you have to keep stirring it because it will catch on fire. Okay, Sabina, it's
No.
yeah, bonus quiz. There you go. There you go.
Did you
Bonus
pay
question.
attention? You
Yeah.
guys are
Did
always
you
giving
come
us
to
bonus
Did you
questions.
come to class? Did you come to class and get the recipe? Hmm. All righty. We only really have one more thing to do. General and local anesthetic agents. So there's something called balanced anesthesia, and you won't actually hear this in practice, but when you hear anything with balance before it, balanced anesthesia means given a combination of things that that are like anticholinergics, those that dry up secretions. In fact, your patient in surgery will actually be given some atropine because that dries up secretions. And certainly it's a cocktail drug, something that relieves pain, something that causes muscle relaxation, something that affects your level of consciousness, and something that causes amnesia. And so that's one reason why when you go through surgery and you're given anesthesia, you have a very hard time remembering what happened because of the combination of the balanced anesthesia that they gave you. And so, of course, there's a difference between general and local. General anesthesias are analgesia, which is no pain, amnesia, which is you can't remember, and unconsciousness, because it's a total general effect on your entire central nervous system. It involves wide CNS depression that you can imagine, and certainly it can be harmful, particularly those that have respiratory diseases, which is why your patient will go into surgery, the anesthesiologist and or the CRNA, which is a certified, which is a nurse anesthesia. Twilight sedation? Yes. Yeah, for sure. There's something called Versed, Michelle, when I had my colonoscopy, and they tell you to go to the beach, and I went to the beach and I woke up and they were done. So yes, absolutely. Plus they give you, yeah, it was awesome. Well, the beach was not so much the other, but they give you something like a little bit of Valium that kind of eases you. Oh, wow, Sabina. Yeah, CRNAs. I've had 3 of my students at Concordia go on to be CRNAs. Yep. Good. Start out with making an A in Pharm 1. And you're on the right track. And then contact us and we'll write you the best recommendation ever. I actually wrote all of them recommendations. So just saying, you can't get rid of us. So let's see. Local anesthesia block the depolarization of nerve membranes. Basically, they're blocks, preventing the pain sensations from going up to the brain, which is why they're called blocks. They deliver the drug. Say you cut yourself, they'll give you some xylocaine with epinephrine. And what that does is it keeps the pain, the deadener, if I can use that word, right centrally located. Xylocaine without epi has a tendency to disperse and absorb faster, so they give you with epinephrine. Let's see what else about this. Key nursing considerations for taking care of your patients receiving general anesthetics. Patients receiving general anesthetics must be constantly monitored, obviously, for CNS depression. And you'll find out also next semester that they also must be moved around a lot. A patient in having a particularly long surgery can develop what they call compartment syndrome. And you must make sure that they maintain mobility as well. And they're not like on one side to where blood is constricted and or limited to any particular muscle group. Let's see, of course, there's respiratory arrest, cardiovascular reactions like hypotension for sure for general anesthetics. Precautions, safety, injuries, skin breakdown, that's something certainly you need to worry about, particularly next semester. We'll go over this as well. Skin injury, skin breakdown, dealing with loss of sensory sensation and mobility as well, and certainly decreased stress and anxiety. A lot of people, like my mother, when she had her hip surgery, she got really, really, really aggressive. My stepdad actually tried to prevent her, tried to hold her arm so she wouldn't pull out her Foley, and she had a lot to say to him about that. She told him he better stop that or he'd be sorry, and she was the nicest person God put on earth. So, general anesthesia, particularly in the elderly, is oil, it's fire and gasoline. One of my patients in the nursing home hallucinated like crazy following a knee replacement, and just did some really off the wall stuff. He was in a room with his wife and he tried to feed her the remote control, and just profound hallucinations. So let's see, when asking just means having patients sign consents, things like that, right? Absolutely, yeah. Of course, before general anesthesia, unless, of course, it's an emergency. And remember, the doctor is always in charge for getting the consent, although the nurse will be given that task. I've had a couple of patients. I went to a family member one time. It was an emergency situation, and I was getting consent for the surgery. It was, I don't know, I think he was a urologist. And the patient had questions before surgery, and they wouldn't sign the consent. And I was actually a house supervisor at the time. And anyway, I became not the surgeon's favorite nurse. However, because of the questions, the patient didn't have the surgery. And it turned out that it was good because the patient had a reaction to some form of the medication that was going to be given in the surgery. So certainly dodged that bullet, because ultimately it's the physician's responsibility to explain the procedure, because you're not going to be doing it. So always make sure we stand in the gap for our patients, for sure. So that was a long, drawn out way about saying one very simple statement. So, anybody have any questions?
So one thing I wanted to add about opiates is when you have somebody who's elderly, we definitely need to make sure that we're giving lowered doses of that medication, because the metabolism of the drug is a lot slower in elderly patients. And then we also want to consider opiate naive patients as well. I can't speak. So we're going to want to try for lower dosages also. Patients who are alcoholics, or as we talked about prior, are drug abusers, we're expecting difficulty controlling their pain, because alcohol works on the same centers of the brain as opiates do. So those are just kind of some things I wanted to add as well. And I guess older adults too can have some different side effects as well, similar to anesthetics. I don't know, does that sound good, Dr. K? I feel like.
Oh, that sounds fabulous. That sounds fabulous. That sounds fabulous, though.
Yeah, definitely want to make sure that we are looking at the patient's history and things like that with pain control, because we don't want a patient to come out of surgery and just have a really, really hard time controlling that pain. It will definitely benefit you calling the doctor beforehand and trying to plan that beforehand. I know I've had patients come out of surgery with no post-op pain management orders, and if you wait, it's going to be difficult to get those, and that patient's not going to be able to sleep.
And it's always better
So
to
you can
control
imagine.
pain versus chase it. It's very difficult to catch up with pain just because of the central nervous system effect on your pain receptors. So it's always easier to control it than chase it. Me? Absolutely. Absolutely. They'll get Sabina, absolutely. They'll get a loading dose of pain. Though before you leave surgery, you get a loading dose of pain relievers, and they're usually narcotics. They're usually narcotics. Absolutely. So Alex, what do you mean? Can you jump in and like explain?
Yeah, sorry. Can you hear me?
Yes.
Just for like studying purposes for all the drugs that we've gotten in the study guides, the drug guidebooks have a lot of information, and I was just curious if you wouldn't mind giving us kind of like the basic things we need to know for each one of them going forward for studying.
So what can you give me an example?
Sure. For Xanax.
Anti-anxiety, right? When would you take Xanax?
Say it again.
When would your patient take Xanax?
Well, they would be given it for an anti-anxiety. And
Absolutely.
because it acts quickly. It'd be for maybe some sort of like panic attack or disorder.
Panic attacks, absolutely. Absolutely. So what is anxiety anyway? Yep. Bedtime, absolutely. That's a good time to give it. The synergistic. So it's not given often. What drug class is Xanax? It's a benzodiazepine. So there you go, Sabina. It's a benzo. They can be addicting. They must be tapered. CMS now says that you can only, if you're giving it PRN, you can only give it for 2 weeks without a new prescription. It's not recommended in the elderly. It's for benzos are given for anxiety, and they also can be given for seizures as well.
Reversal agents.
What's that?
Know if there are any reversal agents or any contraindications to the medication.
Flumazenil is something you can reverse it with for sure. There you go, Heather and Alice.
Yep, naloxone definitely for narcotics.
Mm-hmm.
Yeah, I have no idea what you're talking about, but that sounds great.
Mazicon is something that's used for conscious sedation. There's a lot of interesting things that you'll find out as you gather, Sabina, as you prepare to be a nurse anesthetist.
Oh, okay.
There you go, Heather. Pam and Lamb flew fast in there you go. I like that. I like that. That's a good, what do you call it? Not a limerick. Benzos. There you go. There you go. So did that answer your question about the Xanax, Alex?
Yeah, so Michelle, you're correct. So you want to know like the drug class, and then anything. You want to know the drug class, the drugs that are in that class, and if there's anything that's abnormal, right? So most of the benzos are going to have the same side effects, the same usages for the most part. If there's something that's different, you want to make sure to pull that out, because that'll probably be what's on the test, most likely.
For sure. For sure.
Yeah.
All righty. Y'all been a dandy audience. And I just hope y'all have had as much fun as we have. Maybe not. All righty. Y'all are going to do well in this class. 100%. All righty. I'm loving it. All right. So